I was given the task of talking both about the role of the medical oncologist, talking a little bit about the entire treatment landscape, and with perhaps a slight emphasis on PRRT. But let's start with the role of the medical oncologist. And before we get into that, I think it's important to emphasize just how heterogeneous neuroendocrine tumors are. This is not one cancer. This is a family of cancers, and a very diverse one at that. It ranges from the least aggressive to the most aggressive cancers out there. And they vary quite a bit based on a lot of factors. How fast they're growing, what is the tumor burden, whether they express somatostatin receptors or not, whether they produce hormone or not, what is their state of differentiation and grade. Just to illustrate this pictorially, the patient on the left with a solitary small liver metastasis is obviously in a very different situation from a patient whose liver contains innumerable tumors, even though technically they're still both stage 4 metastatic. Similarly, the patient on top with a grade 1 tumor with very few dividing cells, which are stained brown, that's the Ki-67 index, which you've heard about, is in a very different situation from a patient with a tumor, all of whose cells are dividing with a Ki-67 basically of 100%, whose tumor might double in a month in size. And so that just illustrates the diversity of the disease that we're talking about. And so we assemble a multidisciplinary team to deal with all the various aspects and complexities of this disease. And some specialties might focus on patients with relatively well-differentiated tumor burdens, well-differentiated disease, low tumor burden, for example, a surgeon. Whereas a medical oncologist might be focusing more on patients with more aggressive systemic disease. So one way of looking at this is the patient in the center and all the various different specialties contributing in some sense to different aspects of the disease based on whatever the need is. And in this model, the medical oncologist is focused on systemic therapy, whether we're talking about drugs that are administered orally or intravenously or injectable drugs like somatostatin analog. But I think a more accurate way of looking at this is that the medical oncologist and the patient are really partnered together throughout the entire course, throughout the entire journey. And in this analogy, if you like sports analogies, the medical oncologist is akin to the quarterback, really managing the therapy, in some cases managing the therapy individually, in other cases passing things on to other specialties, like for example, interventional radiologist if we're talking about a patient with liver-dominant disease who requires embolization, or to the nuclear medicine doctor if we're talking about a patient who is most appropriate for peptide receptor radiotherapy, or to a surgeon if we're talking about patients with relatively limited metastases that are candidates for debulking surgery. When we're talking about these various specialists, it's important to recognize that in most cases they're familiar with a particular slice of the pie, a particular aspect of treatment. So the endocrinologist might be most familiar with managing hormonal syndromes. It might be helpful for managing a complex hormonal syndrome like Cushing's syndrome. And the interventional radiologist may be focused on liver metastases, in some cases to the exclusion of understanding of what's happening outside of the liver. The surgeon is particularly familiar with well-differentiated, slow-growing tumors and may not be that aware of what's going on if the patient has a very aggressive, poorly differentiated tumor. And the nuclear medicine doctor is, of course, familiar in this context with patients whose tumors express high levels of somatostatin receptors, which not all neuroendocrine tumors do. So when you're talking about a net oncologist, I think it's important that this physician be really familiar with the entire spectrum of the disease, and really familiar with all the therapeutic tools that are out there. And it's important in that context to try to be as non-biased as possible. And it's difficult because I think most doctors, have a particular treatment or set of treatments that they're most comfortable with, they're most familiar with. And the tendency is to, focus more in that particular type of treatment. So it's important to keep an open mind for a NET generalist rather than, be specialized and focused on one particular type of treatment. Now, does this person necessarily need to be a medical oncologist? I think the answer is no. I think there are cases where a gastroenterologist or a surgeon or an endocrinologist can really become familiar over years with the entire range of options for NET patients and learn how to refer out to different specialties and become sort of this quarterback figure that partners with the patient throughout the entire journey rather than focusing on treatment. But perhaps the best fit is a medical oncologist who's trained in treating the entire range of cancer, is trained with treating different types of cancer and understanding the biology of cancer. So like I said, it doesn't have necessarily need to be a medical oncologist, but perhaps that's the most obvious fit. And certainly in the United States, most doctors who treat the entire spectrum of neuroendocrine care, referring out to various specialties, are medical oncologists. So let me just present a case that sort of illustrates this multidisciplinary aspect of neuroendocrine tumor treatment. This is actually a patient that I just saw a couple of weeks ago, presented almost 10 years ago with intermittent abdominal pain, also had heartburn and night sweats. CT scan showed a tumor in the tail of the pancreas, some adenopathy, lymph nodes behind the pancreas, and several liver metastases, but not many. Octria scan showed some somatostatin receptor uptake. Because he had heartburn, we measured gastrin level, and that was normal. And so we talked to the patient. We really had all these potential options, and this kind of illustrates some of the complexity that's involved. We could go directly to try to do surgical debulking, resecting the primary tumor, the lymph nodes, and the liver metastases. We could go with a strategy of neoadjuvant treatment, meaning treatment before surgery, followed by cytoreductive surgery, or we could go directly to a systemic treatment, and often we would start with somatostatin analogs, which are the least toxic, but there's this entire range of treatment options out there with very little consensus of how to best sequence them. And so this particular patient was started on octreotide, sandostatin, had stable disease after 3 months. We discussed the case in a multidisciplinary tumor board, which is where various specialties come together to review the scans, the pathology, the clinical scenario, and tumor boards exist in every academic center. They're a very important aspect of this multidisciplinary care. In this case, the surgeon thought that they could potentially remove the primary pancreatic tumor if it responded to therapy. And so we administered 3 cycles of chemotherapy with CAP-TEM. We achieved a minor response. The surgeon felt that further shrinkage was necessary, and so we referred the patient out to a radiation oncologist who administered radiation combined with chemotherapy. Finally, that tumor shrunk sufficiently for the surgeon to be able to go in and resect the primary tumor and also remove most of the liver metastases and the lymph nodes. And the patient remained stable with very little residual disease for approximately 5 years, eventually progressed in the liver. And then we had almost the same discussion as we had at the outset, looking at all these different options. We talked about more surgery. We talked about liver embolization, where we infuse microparticles to block the blood supply to tumors in the liver. We talked about all these various systemic treatments, including peptide receptor radiotherapy. The patient didn't want to undergo surgery, and obviously when we're talking about any of these treatments, involving the patient in the decision is critical. They know, they're in this case, the patient already had surgery, so we knew what he was facing. And instead he underwent liver embolization, achieved a good shrinkage in the tumors that were embolized, but eventually progressed elsewhere in the liver, started everolimus, Afinitor, progressed a year later, and now is being screened for peptide receptor radiotherapy. And as you can see from this gallium-68 dotatate scan, the somatostatin receptor expression is extremely strong. I think this patient will be a very good candidate for peptide receptor radiotherapy and hopefully will respond for a long time. So this kind of just illustrates some of the tools in our disposal and just how many specialties can be involved in particular case. I think I mentioned probably 5 specialties just involved in the treatment, not mentioning even the pathologist who reviewed the slides to begin with, and the gastroenterologist that was involved in the original diagnosis. So about 6 or 7 specialties involved in this patient's case so far. So now moving on to a partial list of the treatments that are available with a focus on systemic treatments. The somatostatin analogs, octreotide and lanreotide, have been discussed several times. They're by far the least toxic, least risky drugs available to us in cancer therapy, and that's why we tend to use them first time. As has been discussed already, they're effective not only at controlling tumor growth, but also at controlling many hormonal symptoms that NET patients experience. So often the first-line systemic treatment that we administer in this disease. Everolimus Afinitor targets a certain enzyme within the cell called mTOR, mammalian target of rapamycin, which is a pathway that's where we see discrete mutations in about 15% of pancreatic NETs, but we see upregulation of this pathway in a much higher percentage of neuroendocrine patients, not just pancreatic NETs. There have been 3 randomized phase 3 studies, placebo-controlled studies of Afinitor in various types of neuroendocrine tumors. The RADIANT-2 looked at neuroendocrine tumors with history of carcinoid syndrome, mostly therefore small bowel, midgut neuroendocrine tumors, and showed a relatively modest benefit. RADIANT-3 looked at pancreatic neuroendocrine tumors, showing a much more substantial benefit, and Dr. Kuntz has already reviewed what these curves illustrate, so I appreciate that. RADIANT-4 looked at patients with gastrointestinal and lung neuroendocrine tumors and no history of carcinoid syndrome, so mostly lung, stomach, colorectal neuroendocrine tumors, again showing a pretty decent benefit. So despite relatively low response rates of only about 5%, we can see significant delays in tumor progression with everolimus, but not so much, I think, in typical midgut neuroendocrine tumors with carcinoid syndrome. When it comes to overall survival, if you look at the curve on the top, actually the survival was a little bit longer with placebo on the RADIANT-2 study. So again, probably not the best drug for this particular disease of typical small bowel neuroendocrine tumors with carcinoid syndrome, but we see trends towards survival benefit in pancreatic neuroendocrine tumors and in these non-functional gastrointestinal and lung neuroendocrine tumors, which are probably the settings where this drug is most appropriately used. Any of you who have been on everolimus are aware probably that the drug does have many different side effects, ranging from mouth sores, diarrhea, lung inflammation, increased risk of infection. Often patients require dose reductions, but most patients can tolerate the drug if they're monitored closely. So we use it primarily in progressive pancreatic neuroendocrine tumors, other non-midgut neuroendocrine tumors, and again, you have to choose patients who are able to tolerate the drug. Sunitinib sutinib targets blood vessel growth of tumors. It was studied primarily in pancreatic NETs. The results were virtually identical to what we're seeing with Afinitor, so it's a perfectly reasonable alternative to Afinitor in this particular population. The side effects are different. I wouldn't describe them as better or worse. Patients tend to get painful rashes on their hands and feet. They can get diarrhea, tiredness, high blood pressure, slight increase in risk of stroke or heart attack. So again, a drug that tends to stabilize disease rather than shrink tumors, and very similar in efficacy to Afinitor. And we tend to choose among the two based on whatever other diseases the patient might have. But in some cases, it's a tough decision. Chemotherapy has been mentioned. I think there used to be a myth that chemotherapy is not active in neuroendocrine tumors. We've increasingly discovered that chemotherapy is active in a certain subset of neuroendocrine tumors, primarily in pancreatic neuroendocrine tumors. There have been a lot of different studies of different combinations with temozolomide, either small subsets of prospective clinical trials or retrospective reviews, primarily showing relatively high response rates, ranging from about 30% to 70%. And when we reported the combination of capecitabine and temozolomide 6 years ago, primarily as a first-line therapy. We observed very high response rate, 21 out of 30 patients responded, and a median time to tumor growth of about 1.5 years. And Pam Kuntz has already mentioned this. I think one of the most exciting data that will be coming out in the last couple of years is her randomized clinical trial of temozolomide versus capecitabine temozolomide. This is going to be the largest randomized prospective clinical trial of a chemotherapy combination in well-differentiated pancreatic neuroendocrine tumors. And she's already given a hint of the results with a time to tumor growth of nearly 2 years with the combination of capecitabine temozolomide. That's quite exciting for this particular disease, metastatic pancreatic neuroendocrine tumors. It's substantially longer than what we've seen with everolimus or sunitinib. And so I think it's quite encouraging. I'm hoping that we'll eventually see studies comparing this combination to everolimus or sunitinib in order to prove whether one strategy is better than the other. And just to illustrate some of the objective response rate that we see with chemotherapy, here are some before and after pictures that I took from our first series of 30 patients that we described. So in some patients with aggressive pancreatic neuroendocrine tumors, high tumor burden, we can see very dramatic objective responses. So the strengths of temozolomide-based combinations, and I think we can say now that probably capecitabine temozolomide is a standard there, are high response rates. On average, this combination is quite tolerable, although there is a risk. About 1 in 5, 1 in 6 patients will have very significant drops in blood counts, and so patients do need to be monitored closely. Until recently, we only had a low level of evidence to support this, but Dr. Kuntz's recent clinical trial, I think, will be an important contribution to the data on this particular regimen. I think we're still working on trying to find validative predictive markers. There's some evidence that a certain DNA repair enzyme called MGMT may predict for response, but not all studies have shown that. And finally, PRRT, which I'd say is the most exciting new treatment that has been developed in the last several years. Between Lisa and Johannes and others, I think we've actually talked quite a bit about it this morning, but I just want to go over it briefly. The target, of course, is the somatostatin receptor. Most well-differentiated neuroendocrine tumors express high levels of somatostatin receptors, and so by attaching a radioactive isotope to a somatostatin analog, you can selectively deliver radiation to these tumor cells. And until recently, the data primarily came from single-arm studies. This is data from Rotterdam, where the therapy was first developed, showing response rates averaging about 30% for midgut small bowel neuroendocrine tumors, about 50% for pancreatic neuroendocrine tumors, and anything in between for the rarer subsets of lung, rectal, gastric, et cetera. And median time to tumor growth, progression-free survival of about 2 to 3 years. And we know, of course, that somatostatin receptor expression, which can be measured either Octria scan or on gallium-68 dotatate scan, NetSpot, predicts for response. That's, of course, not surprising. So the NETTER-1 study, which has been mentioned several times today, was the first randomized study designed to actually prove that this treatment works. It was tested in patients with midgut small bowel neuroendocrine tumors progressing on first-line octreotide, and they were randomized to receive a standard 4 cycles of lutetium dotatate versus high-dose octreotide, double the standard 30 milligram dose, with the primary endpoint being progression-free survival, time to tumor growth. And you've seen the study several times now. There was a roughly 80% improvement in this hazard ratio, the risk of tumor progression. And when it comes to survival, which is obviously what we're really looking for, there's certainly a strong suggestion of improvement in overall survival. Now, this is just a preliminary look at survival that was done at the same time the primary endpoint, time to tumor growth, was analyzed. The ultimate survival analysis will be done in several years, 5 years after the last patient was randomized. But if we look at these survival curves with lutetium versus high-dose octreotide, we can already see that there is what we call the separation of curves, the hazard ratio of a 60% improvement in survival, and with a strong evidence of statistical significance. But this needs to be proven. So where does this fit in? We have a phase 3 randomized study only in these midgut neuroendocrine tumors, but as we've seen, there's very strong evidence supporting its use in a wide range of neuroendocrine tumors, pancreatic, colorectal, even lung. And so as a result of that, the drug was actually not approved just for midgut, but for the more diverse group of what we call gastroenteropancreatic neuroendocrine tumors. This is a group that excludes lung neuroendocrine tumors, but there's certainly evidence that it works in that population as well, even though a lot of lung neuroendocrine tumors don't necessarily express high levels of somatostatin receptors. So not all lung neuroendocrine tumors are appropriate for this treatment, but many are. One of the advantages of peptide receptor radiotherapy is that it's a relatively limited course of treatment. This is not a drug that needs to be taken on a daily basis. It's given once every 2 months for 4 treatments. The treatment day itself is a relatively long day, ranging from about, say, 5 hours to maybe 10 hours, depending on the types of amino acids that are used to prevent kidney toxicity. And perhaps this is a good time to talk a little bit about that. We need to infuse amino acids to reduce the risk of damage to the kidney. And we think that with amino acids, the risk to the kidney is actually negligible with this treatment. On the NETTER-1 study, we had to use commercial amino acids. They contain about 20 amino acids. Anyone here who has had this type of PRRT knows that it's extremely nauseating. Now, that nausea tends to only last during the infusion, but it's a fairly unpleasant experience, and it exposes patients to a large fluid bolus that can be sometimes dangerous if they have carcinoid heart disease. For the vast history of the last decade in Europe, they've been given a combination of only 2 amino acids, arginine and lysine. These are totally sufficient for preventing renal toxicity and much, much better tolerated. And now that PRRT is commercially available, there are compounding pharmacies that can generate these arginine-lysine combinations for routine use. That's what we're doing at Moffitt now. And I can already say from having treated 10 patients in the last month that none of them experienced any significant nausea during the treatment. So as this gets rolled out in various institutions, I think it's important to encourage these institutions, if possible, to go with the compounded amino acid formulations. And I hope that Novartis, which now is the company that's manufacturing this drug, will proceed with clinical trials in the near future to license these arginine-lysine formulations. So, overall, a well-tolerated treatment. There are risks, though, and the main one is bone marrow toxicity. So, about 1 in 50 patients, roughly 2%, will eventually develop either leukemia or a pre-leukemic condition called myelodysplastic syndrome. It's a low risk. It's only about 2%, but this is probably the most significant risk that patients need to be aware of before they embark on this treatment. I'm just going to spend a few minutes on liver-directed therapy. You've heard a little bit from the surgeons about surgery for debulking liver metastases, but many patients have more extensive liver metastases and are not candidates for surgery. In that case, liver embolization can be done. And it relies on the fact that the liver gets most of its blood supply from the hepatic artery, whereas the normal liver gets most of its blood supply from the portal vein. So you can selectively infuse particles into the hepatic artery and either just block the blood supply to tumors or administer either chemotherapy or radiation to those tumors. It's a very effective therapy at shrinking tumors in the liver. There aren't any randomized clinical trials. We have mountains of data from small institutional series showing response rates of about 50% and symptom improvement in an even higher percentage of cases. So Embolization is to a certain extent in the same situation that PRRT was until recently. A lot of data, but none of it in the form of a good quality randomized controlled study. There is a study currently, the RETINET study, that's comparing 3 different types of lever embolization, bland embolization versus chemoembolization. And so I think that will be an important study. So just to try to put things together a little bit simplistically, for patients with metastatic midgut, small bowel, and when we're talking about midgut, we're talking about primarily ileocecal neuroendocrine tumors. Typically, somatostatin analogs are the first-line treatment of choice, but when they progress in somatostatin analogs, we have several treatment options. We talked about liver embolization for liver-dominant disease. PRRT, based on a NETTER-1 study, is proven to be highly effective for patients with somatostatin receptor expressing tumors. I think everolimus is probably the less attractive choice for this particular patient population based on the RADIANT-2 study. For lung, colorectal, stomach, I think again, we have strong evidence with PRRT, not randomized data, but good evidence from single-arm clinical trials. We have evidence for liver embolization, for liver-dominant disease, but again, not from randomized trials. Everolimus plays a more important role in this disease based on the RADIANT-4 study, and there's anecdotal data supporting the use of capecitabine temozolomide, but not nearly enough data as we'd like with this particular combination. And finally, for pancreatic NETs, is perhaps the most complicated treatment decision, because for patients who progress on somatostatin analogs, there's actually at least 5, if not more, treatment options. We talked about everolimus, Afinitor, we talked about sunitinib. I think probably capecitabine temozolomide is more active than either of those two, both as far as tumor response, certainly, but also as far as time to tumor growth. This, however, needs to be proven in a clinical trial. PRRT is also highly active in this population. We see higher response rates with lutetium dotatate in pancreatic NETs than we do in any other subtype of neuroendocrine tumor. And for patients with liver-only disease, we also need to think about liver-directed therapy. And so the challenge, I think, of the next decade is to try to figure out how to sequence treatments. We have really very little data, virtually non-existent data comparing treatment A versus treatment B. We have increasing number of placebo-controlled studies. We don't have any comparative trials. And so Lisa Baudet mentioned the COMPETE study, which is going to look at lutetium dotatate versus everolimus. I think that's going to be an extremely important trial, one of the first to try to sequence treatments. But we need more of this data, and we need better predictive markers to choose the right treatment for the right patient at the right time. Thank you very much.